Start momentarily. Hello and good morning, West Coast participants, and good afternoon, East Coast and our Midwest partners. I am Twin Tran, AAPCHO's Training and Technical Assistance Director. On behalf of AAPCHO, Migrant Clinicians Network, and other members of the Special and Vulnerable Populations Diabetes Task Force, I welcome you to today's webinar on diabetes in special and vulnerable populations, the first in our four-part national learning series. So for today's session, we will be providing an overview of the national effort underway to support health centers in diabetes care and share lessons learned with you from the previous National Health Disparities Collaborative on Diabetes. AAPCHO is the National Association of Community Health Organizations dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders. We are also a Bureau of Primary Healthcare Training and Technical Assistance National Cooperative Agreement holder, funded to provide training and technical assistance that is data-driven, cutting-edge, and focused on quality and operational improvement to support health centers, lookalikes, and newly funded HRSA awardees in caring for Asian Americans, Native Hawaiians, and other Pacific Islanders. And here I will let our colleagues at MCN talk about a little bit about MCN. Jillian?
Thanks, Twin. My name is Jillian Hopewell, and I'll be speaking more in just a moment, but just briefly to introduce the Migrant Clinicians Network, for those of you who are not familiar with our work, we are also a national cooperative agreement funded to provide training and technical assistance to federally funded health centers. There's a number of programs that we have, but we specialize in worker health and safety and environmental occupational health, continuity of care for mobile patients. We have a deep bench in clinical expertise for mobile populations and other underserved. We have a strong program in violence prevention, and then we provide overall training and technical assistance to health centers. And our constituency includes, as I mentioned, migrant mobile patients and other vulnerable workers in particular, clinicians from really looking at a multidisciplinary team, federally funded health centers, and then state and local health departments. And there'll be more about what MCN does sort of in as we go along. But I'm turning it back over to you, Twin.
Okay, thank you, Jillian. So as I mentioned earlier here, we like to recognize other national cooperative agreement members of our Special and Vulnerable Populations Diabetes Task Force that's helping us put together this national learning series for you. Okay, so before we dive into the content today, I want to review a few housekeeping items with you. Here we are looking at an example of the GoToWebinar attendee interface, which is made up of two parts, the viewer window and the control panel window. The viewer window allows you to see everything the presenter will share on the screen, and the control panel window allows you to participate in the webinar. By clicking on the orange arrow button, you can hide or show your control panel. Today's agenda include a 50-minute presentation followed by a Q&A. Please note that all attendees are in listen-only mode throughout the webinar. You may submit questions and comments by typing them into the questions field of your control panel. We will be reviewing questions as they come in, but we'll address them after the presentation. Today's webinar is being recorded, and you will receive an email with a link to view the webinar after after, as well as the handouts associated with this webinar. So joining us today are our esteemed colleagues from Migrant Clinicians Network, Jillian Hopewell and Ed Zierowski. Jillian is the Director of Education and Communication for the Migrant Clinicians Network. She oversees Migrant Clinicians Network technical assistance and training program for migrant and community health centers, health departments, hospitals, and clinicians working with underserved populations in rural and urban health settings. Ms. Hopewell has a master's degree from the LBJ School of Public Affairs at the University of Texas at Austin, and a Master of Arts from the Institute of Latin American Studies at the University of Texas at Austin. She specializes in the policy implications and development challenges of binational tuberculosis care. Prior to joining MCN, Ms. Hopewell worked extensively in international arenas. She spent a year researching the role of indigenous art in sustainable economic development and the continuance of cultural traditions in Ecuador and Indonesia. Jillian also serves as an adjunct faculty member for the Communications Department at California State University in Chico. Ed Zierowski is the co-chief medical officer for Migrant Clinicians Network. In this position, Dr. Zierowski is responsible for the oversight of all MCN's clinical activities. He was present for the first official meeting of Migrant Clinicians Network in 1985 and has been consistently involved with the organization since that time. Dr. Zierowski began his work with migrants as a partner in a private practice in Chambersburg, PA. He later became the medical director of Keystone Health Center, a large migrant and community health center in Chambersburg, Pennsylvania. While attending his administrative responsibilities, Dr. Zierowski also maintained a full-time clinical practice and family practice in obstetrics, including full hospital privileges in pediatrics, adult medicine, and obstetrics. Oh, I'm sorry. In addition to his work with MCN, Dr. Zierowski is an assistant professor of medicine at Johns Hopkins School of Medicine, where he directs an international rural health elective in Honduras. Dr. Zierowski is also the staff physician for 7 county health department TB clinics, Pennsylvania Department of Health, and he currently acts as the TB medical consultant for the Pennsylvania Department of Health, a clinical consultant for 3 separate firms, and serves as a locum tenens family physician for multiple sites. Dr. Zierowski has worked for the health organization on 2 separate short-term assignments, the first in 2009 to 2010 as a special medical consultant during H1N1 influenza pandemic, and in 2014 as a special medical consultant with the Ebola response team in Guinea and Sierra Leone, West Africa. Before we hand over the control to Jillian. Okay, great. So Jillian, we will hand over the control to you.
Okay. Okay, can everyone see my screen now? Twin, can you see my screen?
Yes, we see your
Okay,
screen.
Great. Thank you. Hi, everyone. So I'm Jillian Hopewell, and the bulk of this, of our presentation today is really going to be Ed, but I am here to introduce a lot of the work that HRSA has been funding. Really, it's starting this program year, so 2017, 2018, but really is going through 2020. And because of a lot of reasons that that Ed will be discussing later on in this presentation, HRSA really has decided when they put out their requests for proposals, both for primary care associations and for the national cooperative agreements, that they wanted there to be a very strong, very robust focus on diabetes in particular, so that we could really try and move the needle to improve quality of care, improve our diabetes programs and the services provided to those patients throughout the country in federally funded health centers. So those of you who are in health centers, I'm not sure where everyone is coming from, but you may or may not have heard about the work that HRSA is doing. So we're really doing our best to spread the word about what all of the different entities are doing, because it's kind of a lot and it could be potentially overwhelming. So we wanted to try and break it out. And this will just be the first of many times that you'll hear a lot of this, but we wanted to try and clarify some of these things for you. So we've done this diagram, and these diagrams that follow are a little more detailed than I typically like to do slides, but it's kind of hard to really encapsulate the work without making it detailed. So the national cooperative agreements and the primary care associations have all been tasked with this one goal of decreasing the percentage of patients with A1C greater than 9%. And I mean, greater than 9% is in there incorrectly, I'm sorry. Clearly that's not going to happen without all of you who work in health centers. So this is going to be a group effort, but this is a lot of the work of the primary care associations and the national cooperative agreements is focused around this. So one of the things that we have done is there are a total of 20 national cooperative agreements that have been funded by HRSA, and there's a significant subset of that group, 13 of us, who are funded under the umbrella of special and vulnerable populations. So we have formed a task force, and there are a number of activities that are coming out of that task force, and I'll go into that in a little more detail. At the same time, NAC has been funded to do a clinical change package for diabetes care, and the Special and Vulnerable Population Task Force is a part of that, but it's really a separate effort that NAC is working on with the clinical subgroup. Then each one of the national cooperative agreements is also tasked with both national and learning collaborative diabetes-focused activities. And so I'm going to be showing you some of those. And then there is a diabetes quality improvement peer learning team, which is coming out of HRSA, which involves, some of you may be on that, but that involves health centers, national cooperative agreements, and some PCAs. So wanted to try and lay that out for you. As zooming in here a little bit on the Special and Vulnerable Population Diabetes Task Force, the organizations that were listed in the previous slide that Twin showed you, those are all members of that task force. And activities for this first year include this 4-part webinar series, which this is the kickoff. A learning collaborative that we're collectively going to be working on to test strategies for special and vulnerable populations around diabetes care, and then a resource compendium, which will be coordinated with some work that NAC does. So that's the work of the Special Vulnerable Task Force. We're doing a lot of coordination within that. The clinical change package is, as I said, coordinated by NAC. It's chaired by 2 physicians who work with NAC. And the clinical subcommittee includes clinical representatives from members of the Special and Vulnerable Population Task Force. And that group will be issuing some of its recommendations in the not too distant future. It'll definitely be coming out before June of 2018. So wanted to make sure that you're aware of all of that. The individual and or small group national cooperative agreement diabetes learning collaboratives, I am not going to go through all of these. I just want to make sure that you are all aware that there are a number of different activities that are going on, and some of them are very specifically focused around certain issues or certain populations. So, just for instance, pulling one out, diabetes in public housing, for instance. So if you are a grantee that works with public housing, that may be a learning collaborative that you're interested in participating in, or at least learning about what they do. Similarly, the Homeless Council will be doing things. MCN, as a Migrant Clinicians Network, where we are looking specifically at issues for mobile patients. And sort of, you can sort of see going down through the list. Now, I want to make it clear to you that this will not be the first time, or this will not be the only time, rather, that you will see this information. But we will be getting all of this information out, making it really clear how people can health centers and individuals within health centers can participate in all of these different activities, and really doing our best to coordinate these activities so that it's not overwhelming, so that we're getting out very similar information, sort of the base information, and that it is something that's really productive and moves us along in the direction that we need to all be going. I'm not going into any details about the diabetes quality peer learning team, because that's just one of the peer learning teams. It's not run by our task force, but it's an important component of what you need to do. I didn't include in here, but some of you may have also seen there's also a webinar series that's coming out of HRSA specifically. I did not include that in here because I don't have the details of that, but just so you know that's also another opportunity you can take advantage of. So I want to move on to really the bulk of what our conversation today is about, and Ed Zerweste is going to be doing the rest of this presentation. The reason, just a little bit of background, the reason that we are doing this focus on the Health Disparities Collaboratives, which many of you may have some experience with, and we're going to put up a poll question in just a moment here to determine. In fact, you could go ahead and put that up, Twin, if you want to, and I'll sort of talk over while you're answering some of those questions. The Health Disparities Collaboratives, which many of you may be familiar with, at least to some degree, was an effort that really made some significant strides towards improving diabetes care and then sort of moved out into other issues and other disease entities, but really began with diabetes. And so Ed is going to go through some of the lessons, what the diabetes collaboratives were all about, some of the outcomes of it, and lessons learned from it, so that we don't lose the work that was done there, but really take this as a springboard and look at where can we go from here, standing basically on the work that was done previously. So as you guys are, Twin, what's the status of the polls there?
Okay, so we had closed the poll. Thank you everyone for participating. And here, are you seeing the results, Jillian?
I'm not seeing the results. I don't know if other people are.
Yeah, I'm seeing them. This is Ed. I'm seeing them.
Oh, okay. Maybe I'm just not for some reason.
So let me read off the results to you, Jillian. So 3% indicated that they were a participant in the original Health Disparities Diabetes Learning Collaborative. 21% participants was not part of it but have heard about it. 4% of our participants have still follow the chronic care model from that collaborative. And then 72% of our participants have indicated that they have not heard of the Health Disparities Diabetes Learning Collaborative.
Okay, that's fascinating. Thank you. Thank you, everybody. Well, I'm going to turn it over to Ed at this point. Ed, you should have control over the keyboard and mouse at this point. Let's see if you're able to move my
Not yet. Hi, everybody. While we're working on that, that poll is very interesting and important, I think, because that's one of the reasons why we're giving this webcast today, because we want to thought we should go back in history a little bit, back to 1999, which is now seeming like a very long time ago, so that we don't reinvent the wheel, because there was a lot of work done by the Bureau. There's a lot of money spent on the collaboratives, and a lot of good results came out of that. So first of all, what were the collaboratives? And let's see if I can move this. Nope.
Ed, if you do your arrows, does that work on your don't go down there.
Yeah.
If
I'm doing my arrows,
like the down arrow on your keyboard. Does that work?
Nope. So maybe you just have to. Maybe you'll just have to.
I'll run it for you. Mm-hmm.
Okay. So what were the collaboratives? Let's just go back again to 1999. Next slide, Jill. And what happened was the Bureau was noticing, you know, for years I used to go around the country saying that we're doing great quality care in community health centers. But really, we had no statistical backup of that statement. We really weren't looking at the quality that we were doing. So what the Bureau wanted to do was let's develop a quality improvement model. Next slide. And then to do that, we're going to have to redesign the processes so that we can improve the delivery of care. Next. So that we really had to look at the standards of care and the quality of care. And to do that, we're going to have to use some nationally benchmarked indicators. So we didn't want to just put a Band-Aid on. We didn't want to have a cookbook approach to this. We really wanted to do this in a very comprehensive way on a national basis. And so we decided to do diabetes first. And so the way it turned out was the key elements that we were going to have is that what we really wanted to do was change primary health care practices, not only on the clinical side, but also on the clerical side and the administrative side, in order so that we could actually improve the health care that was provided to everyone, and to also eliminate health disparities so that the migrants and the homeless and the undocumented people would not be left out of these improvements. And so part of this also was we had to have a quality improvement initiative that would be integrating the following things: a delivery systems design, and I'm going to go into each one of these in detail, organization of healthcare, clinical information systems, community resources and policies, self-management principles, and finally decision support. This was not going to be time limited, meaning that initially we didn't know how long the collaboratives were going to last, but what we wanted to do was to instill a system that would live on after this time. And unfortunately, I see that only 4% of you are still doing this somewhat 17, 18 years later, which is kind of disappointing to me. But it may be that you're actually doing it and just don't have a name to it, don't really relate it back to those initial times. Next slide, Jill. So the partners in this collaborative were all health centers. It was a voluntary thing, so each health center could volunteer to be part of this collaborative. The national cooperative agreements like AAPCHO and MCN and Healthcare for the Homeless and NAC were all involved with this. The National Service Corps was involved. Not only health centers, but also FQHC lookalikes were involved. Obviously the Bureau of Primary Health Care, and then we brought in other partners. We brought in the CDC, who was really very helpful, especially with cancer and diabetes. And then the core of the instruction was actually being done by the Institute for Healthcare Improvement, IHI, who really taught us all the improvement side. They decided to divide us up in clusters so that we would have regional meetings and not have national meetings. So there, you can see on the map where you would fall. There's the Northeast cluster, the Southeast cluster, the Midwest, the West Central, and the Pacific West. And then part of the Pacific West was also Puerto Rico and the Virgin Islands, and American Samoa, Guam, and the other islands that are trust territories of the U.S. So that way, when they brought us together, we could just be brought together in regions. Now, this is the structure. This is the chronic care model that IHI brought to the table to instruct us how to change what we were doing in our community health centers to improve the quality. And I'm going to go through each one of these fairly briefly just to tell you what the structure was. So first was the community resources and policies. So whenever you're looking at trying to improve quality of care, you have to look at your community. We are community health centers. So we had to go out and identify those community resources. Let's focus on diabetes today. So what were those community resources related to diabetes? The American Diabetes Association, other local organizations that would have something to do with diabetes. We wanted to make sure then that our patients were aware of those community resources and make those community resources easily accessible to our patients. We then wanted to get in some sort of a collaborative relationship with those community agencies so we could work together to improve the diabetic care of our patients. And then finally, we wanted to assess the needs of the community. What were the things, what were the gaps out there in our communities that we needed to fill that where our community could come together. Maybe there weren't places for us to exercise. There weren't sidewalks. There weren't parks. There weren't areas that were easy for our patients to exercise. Next slide. So next is we wanted to look at the health systems and the organization of the healthcare. What was the actual organization of the healthcare in our health centers? And so we wanted to make sure that quality was included in our annual business plan, in our healthcare plan, our federal grant. We had to talk about quality for the first time. It seems strange now for all of you who are doing a lot of quality work, but that back then we really didn't have an emphasis on quality. Was it in our organization's strategic plan? And then we wanted to put our collaborative goals into our mission and vision statements. We wanted to make sure that our mission and our vision of our community health center had an aspect of the collaborative quality improvement goals. We wanted to make sure that performance improvement model was part of our organization. We wanted to institutionalize that into our organization. We wanted to also make sure we had buy-in, and this was a difficult thing in the beginning. We had to have buy-in from the CEO and the medical director. We had to make sure we gave time to our staff to have quality improvement meetings and to have quality improvement activities. We had to make sure that management and leadership bought into this, and that financially we put funds out there, that we actually paid somebody to be the quality improvement manager. And then we wanted to actually input those performance appraisals into our job descriptions of our employees, that part of your job description was a quality improvement aspect, no matter what your job was. So the next aspect was decision support. What kind of decision support could we give to clinicians on the front lines? Well, we wanted to go back to evidence-based guidelines. We wanted to go to those guidelines that we knew that if we followed those guidelines that were evidence-based and we actually improved these things, that our patients, when they came through the front door, actually were leaving with an improved health outlook. So we looked at the American Diabetes Association guidelines for care of diabetics, making sure that all patients had foot exams at least once a year, that they had at least 2 hemoglobin A1Cs that were at least 3 months apart, and that hopefully the hemoglobin A1C would be less than 8. We wanted to make sure they were getting annual retina exams. We all know that if you have uncontrolled diabetes, the blindness is one of those poor outcomes that can occur. We wanted to make sure that lipids were checked, and if the lipids were high, that they were being treated, and we wanted to make sure that blood pressure was under control. So we would avoid those things like heart attacks. Then also in decision support, we wanted to have protocols for diabetic care. For example, in my health center, we weren't doing good foot checks. And so we decided to do a PDSA cycle. I'm going to talk about that in just a minute, a rapid change cycle, where we wanted to find out how we could get our clinicians to do a better job of doing foot checks, that monofilament check of the foot to see if there was any sensory loss in the diabetic. And so we had our nurses make sure that all diabetic patients had their shoes and socks off before the clinician saw them. And that didn't improve much. We went from like 20% to 30%. So that one didn't work. So then we decided, well, maybe we should have somebody else do this. So we decided to have the medical assistants actually do the foot checks. We trained them on the monofilament. We showed them how to fill out the chart. And then we did a rapid PDSA cycle for them over 2 or 3 weeks on just 2 or 3 clinicians, and found that they did a great job. So that in a year, we went from 30% of our diabetics having foot checks to over 90%. So that's just a protocol that you could set up. Next, how do you integrate generalists and specialty care? How do you make sure that you're tracking those people that you're referring to nutritionists or you're referring to endocrinologists? And next, how do you get buy-in from the providers to follow these guidelines? You know, clinicians like to kind of do their own thing, but we wanted to make sure, hey, these are national guidelines that if we follow them, our diabetics are going to be doing better. So let's make sure that all are providers. So we did peer review type things, looking at our diabetic care to see who was doing a good job and who wasn't. And we need to counsel them to get on board. Next slide. So the next, we wanted to look at our delivery system design. How are we actually delivering care? So we wanted to get a very proactive, well-patient diabetes visit instead of the crisis management. At that time, there was a lot of crisis management and sick and acute visits. We weren't really planning diabetic visits like we are today. So we wanted to make sure that was a very important part of the chronic care model. And to do that, we had to redesign the patient visit and integrate team care. Instead of just being clinician focused, we had to get other people involved, behavioral health, nutritionists, community health workers, so that we had better flow and better quality of care. Next slide. So here's the team concept. It's not just the clinician. If you want to improve a diabetic patient's care, you have to have all of these people involved. Dental, podiatrists, other office staff, the nurses, the MAs. Like I pointed out, our MAs became a very important part of our diabetic team. The front office staff, making sure patients are getting in. And the no-shows are being followed up. Obviously, our providers, our clinician had to get on board. And then the outreach workers. You know, we found out that sometimes the outreach workers can be the most important person on the team. Let me give you an example. In Florida, there was a great actual study done where they had their diabetic patients split up in two groups. One group got traditional care, and that care was this comprehensive care. Then the other group had that traditional care, the comprehensive care, but on top of that, their community health workers had group meetings with diabetic patients. And oftentimes these community health workers are also diabetics themselves. So these were culturally appropriate, linguistically appropriate community health workers that sat down in a group once a week or once every other week and just would chat about things. And these community health workers were educated on diabetes, and they would just talk about issues that their patients were having, especially those patients that were out of control. And what they found after a year, when they compared these two groups, the group with the community health workers had a much better outcome with their hemoglobin A1Cs than the traditional ones. So just adding the community outreach workers had an extremely important, significant effect. So that's why the team concept is so important. Next slide. So next we go to clinical information systems. And back in 1999, this was a real issue because this was before we had broad EHR implementation. So we had to get a population of focus. So for example, in my health center, I was part of the collaboratives in 1999. I was the medical director of my health center, and we looked at my 250, 260 diabetic patients. And I thought I was doing a good job with my diabetic patients, but I didn't know what I didn't know. And at that time, once we got all my diabetic patients into a chronic care registry, patient registry, I found that there were 20 or 30 of my patients I hadn't been seeing. They were no-shows that we didn't follow up on. They missed appointments and didn't reschedule, and their diabetes was out of control. So once we started focusing on those patients, we were able to improve greatly. So it's really important to have in clinical information systems. Now we have 26 million patients that we are reporting statistics on through our UDS every year, right? But back then we weren't reporting anything statistically on our quality. Next slide. So then we actually build these registries. We built DEMS for diabetes, then CVDEMS for cardiovascular and diabetes, then PECS was the final thing we brought on. And some health centers are still actually using PECS as an add-on to their EHR because unfortunately EHR sometimes do not have really good chronic care management software. Some of you use I2I, and there are some other add-ons out there. And some EHRs now are really having focus on chronic care management. Next slide, please. But it was very important to get this information in. And then I want to point out that we're now reporting on a lot of this information, but what I find when I go around the country and look at health centers, we're very good at inputting statistics, but we're not so great about analyzing those statistics, and then after analyzing, actually doing something to improve what we're finding. And finally, one of the things that I think is the most important is self-management support. So self-management support is really where the patient is accountable for the disease management and health outcomes. I mean, let's look at this. Who has the most vested interest in doing well in their diabetic care? It's the patient themselves. So the more we can invest in them and educate them, the better chance we are that they're going to take control of their diabetes and do better. Next slide. So educational increases the patient's ability to make informed decisions about the care they receive and the health outcomes. And also self-management contracts. We had them actually sign contracts. And the next one, they're going to set the goal themselves. Then they sign a contract. I'm going to exercise. I'm going to lose 10 pounds. I'm going to watch my diet closer. I'm going to make sure my hemoglobin A1C goes from 10 to 9 over the next 6 months. And let me just give you an example of this. I had a patient of mine who was an African-American woman in her 50s who was a migrant farm worker, and she'd come from Florida. And during the winter, she'd had a heart attack. And in the hospital, she was told she was a diabetic, and her hemoglobin A1C was way out of control. It was 14. So at the time of discharge, she was handed a slip of paper that was a 1,200 calorie ADA diet. She was given a prescription for metformin to take 1 twice a day, 30-day supply, and she was discharged. And that was it. She came to me. She took the 30 days, then didn't refill it. She had a 3rd grade education, so she really couldn't read very well, and she didn't understand the diet. So when she came to me, she was still at 14, her hemoglobin A1C. She didn't understand diabetes. So I sat down and spent a lot of time explaining to her what diabetes was, why she needed to be on medication, why she needed to lose weight, why she needed to exercise, and why she needed to watch her diet closely. But the smartest thing I did was I had our nutritionist talk to her. She was actually the cook of her migrant group. There's about 30 guys in her camp, and she cooked all their meals. So our nutritionist talked to her, and then when she found out she was the cook, she volunteered to go out to the camp, and she actually watched her cook for a couple hours and gave her some great tips on how she could cook a healthier meal, not only for herself, but also for the workers. And she actually went out 2 or 3 times and helped her cook. So by the end of the 6 months that we had her hemoglobin A1C got down to about 9. She lost about 10 pounds, and she was learning much more about her diabetes. And then she left to go back to Florida. She came back about 6 months later, and I saw her hemoglobin A1C was now 7.8. She'd lost another 15 pounds. So I said, boy, you must have had a great doctor in Florida. And she said, well, not really. I went to her one time, spent about 10 minutes with me. She refilled my prescription, did a hemoglobin A1C, and it had come down, and that was it. And I said, well, how have you improved so much? Why is your hemoglobin A1C now down almost to really perfect range? You've lost another 15 pounds. And she said, because now I am in charge of my diabetes. Now it is up to me to make sure that my sugar stays under control. I'm checking my sugar every day. I'm watching my diet. I'm exercising more. I'm going to get my weight down. You're not in charge of my diabetes. I am in charge. And that was a huge red light for me. It really taught me that self-management, if we're going to spend money, let's spend money, especially on mobile populations or hard to reach populations. Let's educate them on their disease. And remember, just because a person has low literacy or maybe does not have a lot of schooling, that doesn't mean they're not intelligent and you cannot explain things to them. So the self-management support, there's several things you can do. You can tell them about their labs, give feedback to them, tell them what you're doing. You can give peer support. I told you about those community health workers. That sometimes is an excellent way to help with self-management. You can do behavioral change, get your behaviors in there. Maybe, you know, it's been shown that a lot of diabetic patients are depressed, so make sure you're addressing their behavioral issues, their weight control, smoking. Empower the patient to talk, ask questions of the provider, make them a very aggressive consumer. And also, then you're going to end up with an informed, activated patient. Next slide. And if you do all this, then you're going to get improvement. So let me show you some of the things we found. We found that there's functional outcomes. We saw decreased wait times. We saw more patients were getting 2 A1Cs. They had appropriate referrals. There were more patients getting documented foot checks. And then there were better clinical outcomes. Hemoglobin A1Cs were coming down under 8. Blood pressures were coming under control. If appropriate, they were on aspirin. People were stopping smoking. So looking at the collaboratives, we also did the PDSA cycles. And again, I'm not going to go into this in detail. Hopefully a lot of you know what this is, but that's very rapid change things where you have an idea, you get a small portion of your patients, you try it out. If it works, you institutionalize it. If it doesn't work, you throw it out and do something else. And you do a lot of these small changes, and gradually you go up this hill in quality improvement. Next slide. So diabetes, it started out with diabetes 1 and diabetes 2, and then Jill, go to the next slide. And so really what we found that was very beneficial was the chronic care model works. It's a population-based model that relies on knowing which patients need care, assuring that they receive knowledge-based care, and actively aid them to participate in their own care. And next, we found that the improvement model, how to test change in a system of care in a fast and effective way using that PDSA cycle, ensures that changes are an improvement and expand the changes throughout the practice. And finally, the learning model that we did, and I'm going to talk about that just briefly here in a minute. The learning model worked. If you bring people together in a setting and really do intensive training, then when they go back to their health centers, they're going to institutionalize those changes. Next slide, Joe. So this was kind of phase 1 of what we did. And what they did was they brought us into these clusters, and they usually brought 3 or 4 people. But was the medical director, maybe the CEO, maybe the quality improvement person, or the CFO, people that were going to be involved with making sure that this got started in their health center. And we had 4 learning sessions. Once a quarter, they brought us all together for 3 or 4 days, and we had these intensive learning sessions to learn the chronic care model, to learn PDSA cycles, to find out what we were doing in our health centers, and talk to each other. Then phase 2 was to sustain and spread. So first we start with my diabetic patients. Then once we got all those system changes going, we spread it out to all the rest of our health center. And then after diabetes, we went to cardiovascular disease, hypertension, and depression, and asthma, et cetera, et cetera. And we continue to report and progress through our national goals. And now that's part of the UDS. Now we're reporting on 16 clinical measures, one of which is, in your health center, what percentage of your diabetics have a hemoglobin A1C over 9 or out of control? Next slide. So eventually we had 334 centers in diabetes, 54 in cardiovascular, 60 in asthma, 53 in depression, 12 in cancer, and 10 in prevention. And then the money ran out. There was change in administration, and the collaboratives died. Next slide. But what we found was, when we looked back at the outcomes, what we found was there were almost 60,000 people that we had in that initial group of chronic care registries. And this was the first time we actually could look at a group of patients. Before that, we didn't have that. Now we have 26 million people that we're tracking. There was a major improvement in glucose control. There was improved blood pressure. There was improved asthma, people using drugs for asthma. There was a high rate of follow-up and improvement symptoms of their depression. There was an increase in patient self-management. There was also here's just the numbers. It started in April of 1999 and went up to about 2003, 2004 before it finally ended. Next slide. And this was what was really interesting. When we started, the average hemoglobin A1C, the average, now this isn't the people over 9, this is just the average of all our diabetic patients, was 9.8 in that registry. By the end of that first year, we brought it down to 8. By the end of the second year, we brought it down to 7.8. By the end of the third year, we brought it down to 7.4. So look, we knew this worked. We went from 9.8 to 7.4 in 3 years. So we knew that if you actually did this, it worked. So now we're going to ask another polling question. How many of you know what percentage of your patients, and I'll give you a hint. Right now, 32% of health center patients have hemoglobin A1Cs over 9, out of control. 32% of our diabetics are out of control. Do you know what percentage of your diabetics have a hemoglobin A1C over 9? So we can open the poll now. And I want to know, because all of you on the phone, I don't care what you do at your health center. I don't care if you're a front desk, if you're a community health worker, you're a nurse, you're a clinician, you should know this number. Because it should be advertised. This is one of the things your health center has to report in your UDS every year. So do we have results of that? Only a third of you know. So when you go back, 2/3 of you don't even know. When you go back, ask, because here's what, if you can go to the next slide now, here's what we know in health centers right now. And that is that the percentage, and this was in 2016, the last UDS report showed that 32.1% of health center patients have hemoglobin A1Cs out of control, 9. Okay, and we haven't moved that bar. We've been around 31% for the last 4 or 5 years. That is why the Bureau of Primary Health Care is pushing this year on diabetes, because we're not doing as well as we could do. However, there are 6.5% of health centers who are at or below the Healthy People 2020 goal of 16.2%. Okay, 16.2%. So maybe one of your health centers is there. If 6.5% of health centers can get there, certainly more health centers can do it. So what we're pushing really hard this year is to move that bar up, not 6.5% meeting the 2020 goal, but 15%, 20%, 50%, 60% of our health centers should be there. It's a doable thing. We're just not doing it. Next slide. And just to look back at the end of the Health Disparities Collaborative, they did, JAMA did a report on, this is the private sector, their average hemoglobin A1C was 8.9 for blacks, 8.7 for Asians, 8.8 for Latino, 8.4 for whites. This was the average hemoglobin A1C. And remember, I told you at the end of the Health Disparities Collaborative, where we were, next slide, Jill, where we were was at 7.4. So we knew if we did this chronic care model, we could do better even than the private sector. Right now, I don't know what our average hemoglobin A1C is. We know that 30% of our patients are over 9. So we're probably still right in that 8, 8.5 range. We're not at the 7.4 where we should be. Next slide. So this Health Disparities Collaborative also started a lot of innovative programs. I'm going to spend the next couple minutes just telling you about the Migrant Clinicians Network, one of our programs that's now 21 years old, and we started the diabetes component of this during the collaboratives in 1999. And that's called Health Network. And we call it a virtual patient navigation, bridge case management, medical record transfer program. It's paid for by the Bureau of Primary Health Care. We're funded by the Bureau. And if you have a patient who's going to move or going to be mobile, and you're thinking you're going to lose them to continuity care and they have a chronic illness like diabetes, then you can sign them up with us. It doesn't cost you anything. It doesn't cost the patient anything. The patient's criteria are they're already mobile or they're likely to move. They're in need of a clinic for a follow-up of any health condition. We do diabetes, but we do any health condition now. And what you have to do is you have to fill out an enrollment registration or let our health network associates do that for you. If you call us, we can actually do it for you. And the most important part of that registration form is we get not only one, but we get 3 or 4 contacts of that patient. Not only their cell phone, but their moms, their uncles, their best friend, so that we can find them when they move. We have them sign a consent form, and then we have you send the medical records. Then we contact the patient on a regular basis. For diabetes, we may contact them every 3 or 4 months. We also contact the clinics, your clinic, every 3 or 4 months to make sure they're still into care. We help them get into care. We make sure they have resources. If they need transportation to get to the clinic, we make sure they do that. We transfer their medical records no matter where they go, and then we send the reports back to you. If they move, you get their hemoglobin A1Cs, you find out where they are. We're now working with almost 3,000 clinics in over 111 countries. We do a lot of tuberculosis work, and so sometimes people are actually going out of the country. And what we found is, next slide, Jill, is we've now signed up over 11,000 health network people into this program. And I'm going to end on a case history. This is a diabetic patient. We're going to call him Fernando. Oh, that's not his real name. He's a 56-year-old migrant farm worker who was diagnosed with diabetes at age 49. He traveled each year from South Texas to Minnesota or wherever you could find the work. So we enrolled him in 2002 in Minnesota. Then he went down to Texas. Then back that year he decided to go to New York because there was work there. Then back to Texas. Then back up to Minnesota. then back to Texas, then back to Minnesota. Then that year he decided to go down to Arkansas before he went back to Texas, and then he went back to Texas, and then he went back up to Minnesota. And then finally, after about 11 years, we closed his case out in 2013 because he said he was going to retire. He was no longer going to migrate. But over that 11 years, what we found was that we made 46 clinic contacts. We talked to him 124 times, and some of those were self-management kind of calls. Was he taking his meds? Was he exercising? We transferred his medical records 9 times to 6 different clinics. And then the next slide shows what his hemoglobin A1C did over those years. When he first signed up with us, his hemoglobin A1C was 14, out of control. And you can see over the first couple of years, he was really good, and we got him down under 8. But then he kind of fell off the wagon there in the middle years. He wasn't taking his medicine. He wasn't going to clinics. But then the last 3 or 4 years, he came back into care. And in the last 3 or 4 years, his hemoglobin A1C was under 8. It was under good control. So I show you this to show you that even people that are moving, even a migrant farm worker who is moving all over the country with case management can get his diabetes under control. So nobody is out there who can't be controlled. And I think the impact of our health network shows that it's a bridge between patients and their providers. Fewer patients are lost to follow-up. There's a higher percentage of patients who complete treatment. Treatment completion rates then go back to the enrolling institution, and we have improved patient participation. So the final pearls I want to make sure that you remember from the collaboratives are that you need to not only obtain clear and accurate data, but you have to analyze that data. And when you analyze it and you see that you're not doing as well as you should be, 30% of your patients are not under control in diabetes, then do something. Act on it. Act on those results. You need to focus your effort and resources on individuals who are poor diabetic control. Find that cadre of patients over 9 and really case manage the devil out of those folks. Use all your resources, use all your team to help those people. And remember, this is a team sport. Each individual has an important role to play. You don't know if it's going to be the outreach worker, the nutritionist, that behavioral health person, the clinician who might ring that bell for the patient to really get them on board. And finally, self-management is your most cost-effective and most powerful tool in your clinical toolbox. Don't forget, the more you educate the patient, the more they become control of their illness, the better outcomes you're going to have. And I think, Jill, that ends it for me. So
we wanted to open it up for questions, and I think twin questions maybe have come in throughout as well.
Yes. So we do have a few questions that came in. Thank you so much, Ed, for taking us back to 1999 and bringing forth the wisdom that you have learned and experienced. So the first question was, did you engage your dental providers? And if so, how did you engage them?
Yeah, that's an excellent question. And we absolutely did. In fact, our dentist, our chief dental officer, was part of our team. He was part of our team, and so we made sure all of our diabetics got referred to the dentist for cleaning, because we know that periodontal disease increases hemoglobin A1C. Just a good cleaning can decrease the hemoglobin A1C a percentage point.
Great, thank you.
And Twin, this is Jillian. Just to add to that, just so that everybody knows that NOAA, which is the National Network for Oral Health Access, which is another national cooperative agreement, they're a participant in the Diabetes Task Force, and they're going to have some very interesting learning collaboratives going forward about the integration of dental into primary care for diabetes in particular.
Great, thank you, Jillian. The next question was, did you have homeless patients? And if so, how do you manage those who are homeless or transient patients with many chronic health conditions, including diabetes and with severe mental health issues?
Yeah, absolutely. And part of the collaboratives, we made sure that there were pure healthcare for the homeless clinics that were involved in that, and they showed tremendous improvement. Again, you have to have the team approach where you're going to really use a lot of case management, a lot of outreach if you're going to make sure your diabetics that are homeless get under control. So that special population, along with the migrants, we found that the homeless and the migrants could do just as well with their diabetes as people that did not have that condition, as long as they had very specialized treatment teams to look at the barriers that were keeping them from getting good care. It was hard, but it was definitely obtainable.
Thank you. And also just to point out as well, National Healthcare for the Homeless Council is also one of the NCA members as part of this task force, and they'll be able to support health centers in caring for patients who are experiencing homelessness. The next question is, do you know the average A1C for diabetic uninsured patients?
No, you know, we no longer look at that, the average A1C. Now all we're looking at a national level is patients whose hemoglobin A1C is over 9. That's the only reportable thing now. And it's not really broken out by categories. It's only the aggregate that we're getting on a national basis. But every health center, you can also get it per health center. The one disappointing thing for me is that we can't break it down even for like populations like migrants or homeless. So that drill down has not been done, unfortunately.
And so a follow-up question to that is, can you speak a little bit about your data collection and analysis process? How did you identify and outreach to diabetics who showed care gaps?
So once you have a registry of chronic disease, so once you have a diabetic registry, so you know all of your diabetics in your health center, then you can stratify them by which ones are out of control. And then what we did when we found the ones over 9, we paid special attention to those and make sure that they had a nurse case manager, and also that behavioral health got involved, so that then we could find out what's the issue. Somebody actually sat down with a patient. It might have been the clinician, it might have been the behavioral health person, or it might have been a nurse case manager, or it could have been an outreach worker. Somebody sat down with that patient saying, your hemoglobin A1C is 12. We're really concerned about this. We want to help you. What are the barriers? What are things that are keeping you from either not taking your medicine or not losing weight, et cetera, et cetera? So it has to be individualized with each patient. But you use those registries to pull out those patients that are not doing well. Because the patients that are doing, just to follow up, the patients that are doing great, you know, if you got patients that are hemoglobin A1C or 7, you don't need to do a lot of case management for them. Obviously, they're doing well. And so you want to put your money where you're going to get the most impact. So you want to go to those who aren't doing well and really put your resources towards them.
Great, great. So a population segmentation approach where you kind of zoom in on those with the highest HbA1c. The following question is, did you have unfunded patients, and how did they afford their diabetes prescriptions?
Sure, I think we all have that. And fortunately now, you know, with 340B pricing, we can get a lot cheaper medications. And part of the job of a community health center is to make sure that all those people that need medications can afford their medication. So that's part of being a community health center. You have to assure that if you write a prescription for metformin, that the patient is going to be able to afford that in whatever way you know you can do it with free pharmaceuticals or a 340B program, et cetera, et cetera.
And so as we're nearing the end of the hour, we're just pulling up questions, some last questions. Do you have a link on the task force? And I think this is perhaps for Jillian more than for you, Ed.
A link to, so we will be sending out information about all of the task force activities. We do not currently have a link per se that will go to, we'll send you someplace that has all the information. My contact information and Ed's contact information is up on the screen right now. And please feel free to email me with questions about the overall work that is being funded by HRSA this year, and I can direct you towards anyone. And feel free to email Ed about any clinical questions or questions about the what happened in the collaboratives or what's happening now, and sort of health systems kinds of questions. I also wanted to let you guys know, give you some information about some of the additional 3 webinars in the series that we are doing as a part of the task force. So the one coming up on December 14th is Housing Instability and Diabetes Outcomes in Agricultural Workers and LGBTQ Communities. On January 29th, Health Center Strategies for Diabetes Screening and Prevention for Children and Adults. And then on February 22nd, Diabetes Clinical Management and Periodontal Care for Diabetes Patients and Individuals Experiencing Homelessness, which kind of combines the first 2 questions, interestingly. But, and then what we can commit to doing is, as soon as we finalize the list of all of the individual NCA learning collaboratives, all the additional opportunities that I laid out, we will make sure to get that out to all of you who've registered for these webinars, so that you have the opportunity to contact those entities directly if you're interested in participating or finding out information about what they're doing. I think this is and there's the last one, and there's twins information as well.
All right, well, so since it's 2 minutes past the hour, we want to respect your time. Thank you so much for joining us on our kickoff call today. Thank you to Ed and Jillian for spending time and teaching us about what you've learned in the previous work and sharing about all the collaborative work. We just chatted in for you the links to the 3 webinars coming up, and then we'll make sure to send out the slides and any information after the end of the webinar. And then please help us by completing the survey as we close out the webinar. But enjoy the rest of your day, and thanks again, everyone, for joining us. Bye.
Thanks.
Thank you, Twin.
Bye.
Thank you, everyone.
Thanks, Twin.
Bye-bye.
Bye.